Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
All right, good morning. Thank you so much for joining us in this webinar. Hopefully you can all hear me. I'm Phil Brazio. I'm an assistant professor of plastic surgery at Cedars-Sinai in Los Angeles. I do a decent amount of lymphatic reconstruction surgery, as well as breast reconstruction, limb reconstruction, and other assorted plastic and reconstructive surgery. But really my focus, especially in terms of research and policy, is in lymphedema. And one of the things that I'm interested in that people haven't devoted a whole lot of attention to is post-traumatic lymphedema. So we're going to talk about that today in some detail. These are the sponsors of the LE&RN Symposium series who've generously contributed to make this possible. And here's a disclaimer that this information is just for your use. It's not meant to be medical advice, and please do see your healthcare provider about health concerns. I have no financial disclosures to make. An advisory for our viewers today, because we are talking about traumatic lymphedema. Some of the clinical images in this presentation are of a graphic nature. They do show intraop photographs of traumatic injuries, so please do exercise discretion. Going through an outline real quick, we're going to talk about some central or basic concepts of traumatic lymphedema. We're going to talk about what we know about it, existing reports, the incidence or how common it is, and how it happens and what risk factors might contribute. We're going to talk about trying to diagnose it and how that might be different from diagnosing other types of lymphedema, as well as treatment and prevention options. And I think really important for this talk, future directions as an area that hasn't really been explored too much in depth as we're gaining a greater understanding of different types of lymphedema and lymphatic reconstruction. So briefly, to review, the lymphatic system, of course, is part of the circulatory system. It parallels the venous and arterial systems and recirculates lymph fluid all through the body and eventually back into the veins. It's made of several components. First, you have the pre-collectors over here. Let's see if I can activate this pen, laser pointer. So pre-collector. And at this point, this is when the interstitial fluid between the cells officially becomes lymph. When it enters these vessels, it goes through these very small collecting vessels, which have valves, as well as a muscle pump function, so that they're actually different from arteries and veins. They can actually pump actively. And then it goes through a network of these. Eventually, at several points in the body, it will usually go through a lymph node, which is sort of a processing center that's full of immune cells that help to process any cellular debris or bacteria or anything else in the lymph. And then eventually, again, back into the veins. We know about the clinical symptoms of lymphedema, which usually include swelling, pain, heaviness, feelings of tightness, various other symptoms that can go along with this. It's staged along with the ISL, International Society of Lymphology classification, stages 1 through 3. There are several other types of classifications as well, but this is probably the more commonly used. In terms of diagnosing lymphoscintigraphy, we usually consider, lymphedema, we usually consider lymphoscintigraphy to be the gold standard still, although there are other modalities as well. And these are 3 different types of abnormalities. Here in A, you see what we often see if somebody has lymphedema because of lymph node surgery or radiation to the lymph nodes because of cancer. We often think about that when the lymph nodes are not visualized here on one side, and you can even see the outline of the leg is swollen, and there's this dermal backflow in the skin and in the foot as well. You see other different types of abnormalities here, which can help us figure out that there's a problem, such as these abnormal tortuous channels, suggesting maybe the main channel is obstructed, or a lymph node that's seen in the deep lymphatic circulation, which doesn't normally light up, suggesting maybe the deep lymphatic circulation is picking up and compensating for the superficial. And this is just one of the tools we use. Another tool we use is indocyanine green near infrared fluorescent imaging, and since that's a mouthful, I'll usually just call it ICG. This is a staging system that was developed at MD Anderson, and it shows everything from normal lymphatic channels, which just look like lines, to blockage here, and then pattern of dermal backflow in this area, to sort of more progressively severe blockages and dermal backflow until you have no channels at all here. And then in stage 5, really, there's not even dermal backflow. The dye really can't go anywhere because the lymphedema, the lymphatic obstruction, is so severe. In terms of etiologies or causes of lymphedema, in the United States, we usually think about iatrogenic lymphedema, meaning lymphedema that's caused because of medical treatment. And that tends to be because of cancer treatment, either taking out lymph nodes to stop the spread of cancer or giving radiation to the area, or both. And that is quite common, possibly up to 1 in 1,000 individuals. Other causes in the United States are somewhat rare, such as infection, which is common more so in the third world, and primary or idiopathic lymphedema that we don't understand exactly where it comes from. Sometimes it's genetic, sometimes it doesn't have a clear identifiable cause, is a little bit more rare. But when we come down to lymphedema because of trauma, the fact is we actually don't understand how common it is. So we undertook a literature review of the existing studies out there to try to figure out what we do know about it. We identified 37 publications representing 338 patients. And what you see here in terms of the type of report is that the vast majority are what's called case report, case series, or retrospective cohorts, meaning something happened, they identified these patients, and then they described it. We don't have a lot of studies where they actually designed a trial to compare two groups. In fact, we only have one clinical trial at all, meaning that the quality of the evidence that we have is not that solid. If you look at the study type now within all of these 37 reports, what you see is that some of them are operative treatment, some of them are non-operative treatment, some of them are how do we diagnose it, and some of them are just simply saying, hey, we think we found lymphedema. And the methodology across these studies is really quite variable. So there's not a whole lot that we can take from this in terms of figuring out what the epidemiology is or what we should be doing about it. And again, this is a lot of data on this slide, but if you just take a look at the top row here, if you look at how many patients underwent treatment across all of these studies, it's only 38 patients that actually underwent any kind of treatment, of which 16 were non-operative, and then various different types of operative treatments. Out of those 38 patients, only 21 of those patients had any kind of treatment outcome even described in these studies. And again, the measures that were used to describe the improvement, of which 16 were said to have been improved, we don't really have objective measures like we like to use in our standard evaluation of our postoperative results from treatment or even non-operative treatment of other types of lymphedema. So what do we take from this? So far, we don't know a whole lot. Well, what about the incidence of post-traumatic lymphedema? How common is it? Here's a paper from 2002 from a group that treated several patients with injury. And they give an estimate that 20 to 25% of patients after some sort of traumatic injury suffer from this complication. This sounds really wonderful until you read the rest of the paper and you're looking for the backup of the numbers from their study that might support this. And in fact, there is none. This is a completely guesstimated number. And so, again, it's not something that you can really rely on. It's unclear what imaging modality they used for this. They don't give a count of their denominator, numerator, or any of the rest. So let's look a little farther and find that there is one single study where they came back to look at patients who had a fracture of the lower extremity. And they tried to estimate how many of these folks had lymphedema by giving them a call. When they called them, 55% of the patients had some kind of swelling, and 14% had recurrent skin infections. The problem is with this study that no further evaluation was conducted. And we know that swelling can happen for various different reasons with and without the disruption of the lymphatic channels. And they were not able to distinguish, because of the limitations of the study, between those different causes. So 55% had swelling, but we don't know how many of those had lymphedema. As for the skin infections, unfortunately, it's pretty common in our line of work, putting together injured legs, that you can have recurrent skin infections because there might be bone underneath that gets infected, or hardware, or the things like that. So while it's I'm quite sure that some of these 14% had skin infections because of lymphedema, it's not clear at all that it was all of them, and it was probably some smaller portion. So we move on, unfortunately, not knowing too much. What else can we say? Well, there is a study. This isn't in necessarily a traumatic fracture type injury pattern, but in burns, at least, maybe we can have some sort of correlate. This is a retrospective study, meaning going back and looking at the past, over 3 months of all patients who showed up to a burn clinic. And out of these patients, 1% had lymphedema, and they were able to actually get them imaging and diagnose this, and try to figure out what are the risk factors. And for them, it did not have to do with the total body surface area that was burned, but rather a weak association with deep excision to the fascia level, so below the skin and the fat, as well as circumferential burns that went all the way around some area of an extremity. And if you think about it, those things kind of make sense. But again, this is one measure, and it doesn't really tell us about blunt force injuries or what we normally think of as trauma outside of burns. So currently at Cedars-Sinai, we are putting together a prospective study. The idea is to have patients with orthopedic injuries included. We're going to ask them some questions. And if they do have swelling, we're going to have them come in for measurements, for imaging, figure out how many of those people have swelling due to lymphedema versus other possible causes. And of course, ideally try to offer them treatment if in fact there is an interruption of the lymphatic channels. So how does post-traumatic lymphedema work? How might it be somewhat different than other causes that we're used to? And when I say that, I really am talking mostly about the most common causes that we see, which are, again, from cancer treatment. So the lymphatic system is arrayed in sort of 2 layers. There's a superficial system, which parallels the veins mostly, and there is a deep system which mostly parallels the arteries. And at the intersection points of the body, here in the groin, the armpit, the neck, and other places, those 2 systems tend to come together. But this is some work done by Hiroswamy, who built on the work of Ian Taylor, who looked at the different territories of skin that were fed by different blood vessels. You see veins here, arteries here, and in the middle here we see lymphatic pathways. And he was able to define the concept of lymphosomes. In other words, areas of the body that were specifically drained by certain lymphatic channels. And although there are lymphatic channels dispersed throughout superficial tissues of the limb, let's say the arm, it may be that some of them are more important than others. And so we come to the concept of critical lymphatic areas where if you injure, for example, the main lymphatic pathway that runs under the superficial tissue on the medial side or inside of the leg, you're more likely to develop a significant lymphatic obstruction that can lead to lymphedema. One of these groups, in fact, one of the ones that we mentioned earlier, almost, I guess, 20 years ago now, did a study using lymphoscintigraphy to check out what happens to the lymphatic flow after any type of injury. And the remarkable thing is that actually in every single patient, they saw increased lymphatic flow. So here on this side, the side that's lighting up more quickly is actually the injured side. And here, same thing. And recall, this is 3 months later, 6 months later. So this is not just a really temporary effect. This is something that happens right away and probably persists for some time. Now, why is it that the lymphatic flow would actually be increased in these? Well, we know that injury causes inflammation, and inflammation causes increased blood flow. As you increase the blood flow and the pressure in the leg, and then there's swelling, more fluid is bound to come out of the vessels, come out of the cells, and end up being collected as lymph. And so the lymphatics are actually pulling double duty. Normally, however, we know that eventually, inflammation settles down, and most patients don't develop lymphedema. So how do some patients go from a temporary injury to a more permanent injury that then progresses or causes problems later? And this probably has to do with the histological progression of lymphedema, or the microscopic patterns of injury that can cause lymphedema progression from any type of injury. At first, obviously, we have a normal lymphatic here. And then here we have ectasia, meaning a dilated or swollen lymphatic. We mentioned that lymphatics have an intrinsic muscular pump. And so in order to overcome that initial pressure, if they're overloaded or if there's some blockage, they're at first going to try to pump harder. Now, if they can be offloaded, if there's an alternative pathway that can possibly be used to drain that lymph, or if we manage to give compression and reduce the pressure in that limb at first, we may be able to get this ectasia to settle back down to normal. But if we get into a bit of a spiral, what happens is that the muscle cells start building up and the vessel wall starts thickening as it's trying to pump harder. Eventually, that becomes so thick and so contracted down that you end up with sclerosis, meaning a totally blocked lymphatic vessel. And again, this is the same mechanism by which in breast cancer-related lymphedema, you have an injury that starts in the axilla, the armpit, and then travels downward and causes blockages farther down the arm. So in traumatic lymphedema, clearly also, there is some population of patients, probably the majority, who are able to compensate. They have increased flow at first, and then we're able to get them settled back down. And then there's some portion where the injury is either too severe or in a very unfortunate location, or there's ongoing inflammation or a lack of alternative pathways, and they end up with lymphedema that is chronic. So let's go into some further insights into how post-traumatic lymphedema happens. We actually know that if you make an incision across a lymphatic channel and then you put that skin together, people don't tend to develop lymphedema just from that. But a really interesting insight comes from this study, which did indocyanine green or ICG imaging of patients with injuries that were bad enough that they needed coverage with muscles from other areas of the body. Okay, so this is a gracilis flap, which is from the inside of the thigh. This is a latissimus dorsi flap, or a representation of it, that comes from the back muscle. And they were able to get these muscles to live and provide good, healthy coverage for these bad injuries. However, muscles don't have intrinsic significant lymphatic pathways that will just sort of hook up back to other lymphatic pathways and heal. And in fact, when they did the imaging, what they saw was that right at the edge of the muscle, all of this contrast, the dye, it just piles right up and sort of skirts the edge of that flap. And that kind of makes sense. If you interrupt the area of lymphatic flow and don't put anything in between that can reestablish connections, maybe that's when you're going to have a problem. Here's another study. These are some somewhat grisly images, and we're coming up on some more, so I apologize, but they illustrate something very important, which is as this group in Japan put fingers back on, and you can do that as long as you hook up blood vessels to let them live. They didn't specifically hook up lymphatics. The lymphatics at this level are really quite small and very difficult to see, even with our modern supermicrosurgical techniques. What they saw was if they managed to get skin to skin, you had restoration of lymphatic flow. So you had not an excessive amount of swelling at the tip. And if you did your ICG imaging, you would see that the dye shows up and then keeps going without building up in the tip or at that site of the skin contact. In other words, skin to skin, lymphatics to lymphatics, it's going to actually have a capacity to heal itself, which is really, truly amazing. In the contrary scenario here, you have somebody who unfortunately cut off their pinky finger somehow, then they put it back on, they hooked up the blood vessels, so the pinky is alive, but there wasn't enough skin to cover. And so on the back of the finger here, they put a dermal substitute graft, that's basically an artificial graft to try to get that skin to eventually grow back. And it does grow back in terms of getting it covered, but that absence of the channel being next to the channel and being able to heal causes this buildup here, and you have a lack of restoration of normal lymphatic flow. How can we extend this concept even further as far as the contact or healing of the lymphatic channels? Well, here's a study again out of Japan showing free flaps that were used to reconstruct and cover extremities and cover limbs. But this time, instead of using muscles, which again don't have significant lymphatic channels of their own, but instead they used skin and fat flaps. So fasciocutaneous flaps is what we call them, and they have lymphatics that certainly run within them and we can identify. Well, in this case down here, they traced out the lymphatics of the leg, and you can see this large tumor that needed to be taken off. They used tissue from the lower abdomen. This is called a deep flap. And they hooked this tissue again into the blood vessels, artery and vein. They didn't connect any lymphatics specifically, but they did orient it such. They turned it 90 degrees so that they knew that the lymphatic channels that they had mapped, or sorry, they didn't turn it 90 degrees, rather, they left it straight. They saw that the lymphatic channels that they had mapped more or less lined up with the direction of the flow of the lymphatics that were already in the legs. When they went back some time later and used their indocyanine green, sure enough, you didn't get this massive buildup down below the flap. In fact, there's a little buildup at the beginning of the flap, which is interesting. But then you see the normal channels lighting up, and boom, you see the normal channels lighting up again in the leg, meaning it's actually connected. Again, in the contrary situation, this is called a skip flap here. It's sort of almost the sort of lower side of a deep flap in some ways. And they use this to reconstruct a defect on an arm but this time they had to turn it 90 degrees, probably because of some restriction in how they were putting together the blood vessels for blood flow. Again, they didn't hook up the lymphatics, and when they imaged, they saw all this buildup here. They saw buildup within the flap, so some was getting to the flap but was not getting out. And clinically, you do see swelling and evidence of lymphedema. So we can tell that it's really important to try to line up skin that would actually contain lymphatic vessels in an orientation that would allow it to do its own healing. Let's illustrate the importance now of critical lymphatic areas. We talked about lymphosomes and how some areas of the limb are more important than others. This is a gentleman who unfortunately had a bad infection and was treated actually several years ago by a partner of mine and required having quite a bit of his tissue of his arm taken off. When you look at it, you might say, okay, but you also might say that actually he has quite a bit of all this tissue back here left. So what's the problem? Well, if you overlay the principal lymphatic pathways onto it, you can see how they intersect here, especially in this area, with his injury. And so he came to my office a few years later, like this. He's a boxing coach, and having to wear his garment all the time was really quite restrictive and tough for him. And he was having a lot of discomfort and pain. So, in fact, we did a lymphoscintigraphy. We injected dye in the hands. Here, the hands up here. Here, the armpits. He's holding his hands above his head in each of these pictures, and you can see that there's contrast building up in that forearm area just before those wounds that he had. Although there is still contrast getting normally to the axilla, this is his problem right here. So we treated him with lymphovenous bypasses, and I actually cut out some of his scar as well. You can see here on indocyanine green the pathway that goes for a bit and then is interrupted here, and this is a patch of dermal backflow here. Here is, again, sort of his hand, his elbow, and here's towards the shoulder. And you can see here this grafted area where there's no flow whatsoever. This is all dark. And the backflow right in front of that blockage. So we went ahead and did a lymphovenous bypass. This is just a schematic to show what that means. But basically, we sew together the artery and the vein under a microscope. And here's what that looks like under the microscope. Each of these squares is about 1 millimeter. So these are two lymphatics. There's some dye in them. They're going to this vein. And here we're using a fluorescent dye to show that that connection is open. Here's another patient who illustrates the importance of critical lymphatic areas. This is a lady's leg. She had a bad fracture and she lost some skin and the tissue underneath the skin here. The normal lymphatic pathway, the main one, goes over here over the medial knee, over the inside of the leg from the front. And what she had here is one of those muscle flaps. It wasn't taken from somewhere distant in the body. It was actually taken from right here, from one of the calf muscles, the gastrocnemius, and it was swung over and a skin graft put on top of it. And you can see that it's healed well. It's covering her fracture, but she was having a lot of problems with swelling, with discomfort and pain. And when we imaged her with ICG, again, this is the pattern we saw. We saw normal lymphatics and nothing at all lighting up in this whole flap area that was in the middle. And then all this dermal backflow showing that there's too much pressure and behind the blockage here, and it's all coming back into the skin. This is a gentleman who actually had a little bit of a strange case. He had a blood disorder, sort of a blood cancer actually, and ended up bruising very easily. He had a really minor injury, maybe, or he's not sure if this happened at the same time, but basically he ended up with bruising here on his shin. 9 months later, he still has this wound. He has fluid and some swelling, and it's really localized to this area, but it's keeping him from doing what he likes. And he's 80 years old, but he's very active. And so we got our lymphoscintigraphy, and it doesn't really show anything. I mean, his lymph nodes are lighting up in his groin up here, and both sides pretty much look the same. You see these kind of nice channels going on either side. Of course, the detail is pretty muddy down here, and that can be the case with these studies. So we went ahead and did indocyanine green imaging, and what do you know? We see normal channels that actually do continue all the way up the leg. They went and drained the lymph nodes in a normal time scale. However, he has a really hyperlocalized injury here that you can see here of these abnormal vessels and some dermal backflow that probably accounts for his swelling. Now, due to his age and the vessels that were already functioning, as well as his wish to avoid surgery, we actually didn't perform surgery on him. We just treated him with complex decongestive therapy. And this got him back to doing the activities that he loved, and it kept his wound healed. So how does this happen locally? You know, if we have these big channels and you just have a bruise and you have the capacity to heal yourself, why is it that we're seeing these persistent injuries in some patients? Well, this is a single report from 1983. Very funny read, actually, if you get your hands on the manuscript, because the author of this report was actually the patient as well, and he was a pathologist, and he thought it was very interesting to go ahead and biopsy his skin and the location of an injury. He had a lot to say about the horse that caused it as well. But what he saw was that after this bruising, the body deposits fibrin, which is basically just it's sort of a generic protein that's used to begin to form scar in the area of the injury. That's part of the inflammatory response. And when he looked for the lymphatic tissue, he saw that the inside of the lymphatic vessels actually was clogged with a lot of these pro-inflammatory proteins. So that's probably our mechanism. And again, these lymphatics usually have a capacity to self-repair, but in the right person, or let's say the wrong person, that might cause a long-standing injury. So we have these patterns that are a little bit different from what we usually think of in terms of the causes of lymphedema that are common. Again, a single large injury in an axilla or a groin or a neck that's easily traceable, and we can easily get around. In fact, even clinically, we know that swelling is part of an injury. Your leg is supposed to swell if you have an injury, right? So infection, fracture, venous injuries, other issues, all of those things can contribute to swelling after trauma. People say it's a normal part of the healing process. Give it time. And within 6 months, most people would consider that to be normal. Outside of 6 months is when we say, okay, maybe this is not a normal part of the process. We ought to investigate whether there's an anatomic lymphatic injury that should be addressed here. But in reality, as far as trying to figure out who those people are, it's fairly rare that 6 months after an injury or 6 months after the last operation for an injury that we're still, that the orthopedic surgeons or whoever treated that patient are still seeing that patient. Follow-up is often very hard to come by, really sometimes at all after traumatic injuries. And certainly more than 6 months in a consistent fashion that would be representative of the population. So we do have these challenges in trying to figure out who has it. We also have, recall this normal lymphoscintigraphy in that gentleman who had that very localized abnormality. So possibly, and here's his ICG again, just as a reminder, but possibly we should be considering other modalities without relying solely on lymphoscintigraphy to rule in or rule out traumatic lymphedema in particular. This is a study out of Japan comparing lymphoscintigraphy versus ICG. And this is a patient with obvious swelling here on the right arm who actually has a normal appearance of the nodes. So somehow contrast is getting to the nodes. And yet, when you look at the very surface with indocyanine green, you see all this disruption, and they were able to help this patient. So they conclude that if you compare the two and you do both modalities of imaging, which probably would be recommended, and you only see a problem on one, the indocyanine green, then it's probably real, and you're probably getting a false negative instead from the lymphocytography. We've talked about how we think it happens. We've talked about how we think we can look for it and the challenges with that. So why don't we talk about treatment options and what we can do about it. So delayed treatment, in other words, after it already happens, we have vascularized lymph vessel flaps and collagen nanoscaffolds, and then we have different types of prevention. So let's talk about each of those. First of all, vascularized lymph vessel flaps really reflect back to the concept that we talked about just a little bit ago when we talked about those skin and fat flaps, the fasciocutaneous flaps that contain lymph vessels that you can potentially orient in a manner that will lead to healing between lymphatics here and lymphatics here and lymphatics in the flap. This is a patient who was treated for swelling as well as this contracted skin graft. And the authors of this study show afterwards that there is good flow sort of across the edge of the flap and then up into the arm. Personally, without imaging that was done preoperatively to be able to compare, it's a little bit hard for me to look at this and be very convinced of it. But if you look at, again, the data from Japan, I think some of that is quite convincing, and it's certainly a very promising area that probably needs to be investigated further. Collagen nanoscaffolds are another tool that we have. This is an emerging technology that uses very tiny strings of collagen protein that are threaded underneath the skin and can serve basically as guides for the regeneration of lymphatic channels across potentially an injured area, as long as there are good lymphatics on one end and lymph nodes on the other end that can help secrete growth factors to attract the growth of those lymph channels. So it may be possible for us to regenerate that without actually having to use tissue interposition in some settings. And Young Nguyen at Stanford has been working on this. Here is an example of immediate reconstruction rather than waiting for the injury to manifest and cause lymphedema. This is from Nicolas Pereira in Spain. And what he saw was that this critical lymphatic area was injured. He has an awareness of this, and he said, maybe we should try to design our coverage for this area to include lymph vessels that can help restore that flow. And so that's what he did. This is a skip flap here. And he connected, as you can see here, the artery and the vein to bring in blood flow. He did not connect any lymphatics directly, but rather just lined it up in the direction of flow. And this patient did not develop lymphedema. There are a couple other patients in this series, I believe patient series of 6, and none of them developed lymphedema. Of course, the problem is that there is no preoperative imaging to show the level of disruption of lymphatic flow, and there's no comparison to say whether these patients would have gotten lymphedema or not. So again, very promising, but no firm answers as to whether this is something that we should all be doing all the time. This is a patient of mine, and this is a pretty severe injury. You see here a large segment of the tibia bone missing here, as well as a fracture of the fibula, and missing skin almost all the way around the leg. You see here all these exposed tendons and muscles, and so you can imagine that we're going to have some pretty disrupted lymphatic flow. And in fact, that's what happened. So here's an image of the fluid actually literally leaking right into the wound. And here's a grayscale image of the right foot together with the normal left, or the less abnormal left foot, showing that we do have nice pathways going up here and absolutely nothing coming up from the right foot. So what did we do? We actually used an omental flap. This is a piece of tissue that contains lymph nodes, and sometimes we can use a small piece of the omentum as a lymph node transfer in and of itself to actually cover both legs. I used 1/2 of it or 3/4 of it for the right leg, and 1/4 of it for the left leg, which is also somewhat injured here. You can see that this is a big, pretty heavy operation here. A lot of orthopedic hardware as well, but the intent was to get lymphatic flow into the flap and then taken up by the lymph nodes and then shunted up the leg. And we had some setbacks. There were some infections in the bone, which required lifting up the flap, but you see it's really contoured nicely. But after one of these other operations for infections in the bone, she ended up developing swelling of the flap. And actually the foot was okay. And when we did indocyanine green imaging here, what you really see is, number one, some of the contrast is getting around it. And then some of the contrast is getting into the flap, but staying there and not getting anywhere else. In other words, somehow we, possibly through the repeated infections, or possibly through having to lift it up and put it back down to treat those infections of the bone, some of the lymphatic pathways of the flap itself were disrupted. And now, unfortunately, we have a tissue flap that itself has lymphedema. So she was referred for complex decongestive therapy, and she's actually much improved. But if she has problems in the future, we actually may consider something like a lymphovenous anastomosis for bypass right within that flap to treat that edema there. The next question, of course, is, I looked at this and I saw not a lot of great veins. I saw at the time of the injury a lot of swelling and potential for infection and other problems. But should this be the type of injury where we see this leaking, where we know this channel needs to drain somewhere, where instead of just trying to get that tissue covered and the infection healed and the bone together, which is no small task in and of itself, do we also try to put together a lymphovenous bypass? For example, draining this into one of the veins of the flap so that we can reestablish lymphatic flow from the very start. These are, again, questions to answer in the future. I'm a surgeon, and I think surgery is great, and we love what we do, but we also know that the mainstay of treatment for lymphedema, no matter what you're doing, is always going to be non-operative. It's always going to be complex decongestive therapy before, after surgery, with and without. And so there is a study that actually looked at something very aggressive, I think most orthopedic surgeons would say, in terms of treating the swelling acutely after the fracture. And what they looked at was patients with orthopedic injuries, and they wrapped them. The idea here is to disrupt that vicious cycle of dilation and then trying to pump too hard within those microlymphatics, and the thickening and then the sclerosis that can happen. So they're trying to disrupt that by normalizing the pressure in the leg early on and seeing whether they could actually get them to their final fixation earlier than if they didn't compress them. And in fact, although normally we're taught in terms of trauma and orthopedic surgery that compressing the tissue can cause injury, in fact, these patients did better. So they actually went back for their final surgery with their swelling resolved in just a little over half the number of days as this other group. Now, this is only one study, and this protocol that they use of waiting so long, it's not, I think, terribly commonly used to wait that long in the first place. So whether that bears out in other scenarios is a reasonable question, but it's certainly, again, thought-provoking as to whether this is something we ought to be doing more commonly. We talked about treating, we talked about preventing, but what about when we are the problem? Well, this is an image from, again, Nicolas Pereira in Spain, and he was presenting this as an example of something that he did before he was really thinking very carefully about these critical lymphatic areas. He saw this wound over the knee, and he saw that he needed to cover it. His plan was to take this piece of tissue here and swing it over, leaving it attached to the base. And you can see how that's healed very nicely here. But superimposed on that, he's drawn that principal medial lymphatic pathway. And in fact, when you interrupt that, you're going to go ahead and keep this from being able to heal back together because you've changed the orientation of the tissue now. And look at the leg. Now we have swelling. So whatever our treatment modality, part of what we have to do and think about, I think, more commonly in the area of trauma, which has not really been talked about, is how can we design our own operations that we use to treat patients to avoid injury and further swelling from lymphedema. So this talk has been a lot about unanswered questions. And in fact, I think this is where the focus really is on this slide of future directions. I think our diagnostics need to improve. Magnetic resonance lymphangiography, basically a form of MRI, is being used by more centers, and it may be helpful to identify in 3D the pathways that are injured or could become injured, depending on what injury or treatment pattern we need. Should we perhaps, after an injury of certain types, be using bioimpedance spectroscopy, which is a type of non-invasive testing to surveil for swelling before it becomes a problem? We do this sometimes for breast cancer patients, for example, after they have an axillary lymph node dissection, to check whether they have early signs of swelling so that we can intervene and stop the vicious cycle before it starts. Prevention is certainly crucial, and this depends on awareness, I think, among treating providers. So knowledge of where those critical anatomic areas are. Should we perhaps be getting routine lymphatic imaging before reconstruction for some of these injuries where we know their high susceptibility? Should we be considering an immediate lymphatic bypass for leaks? And should we have a preference, instead of muscle flaps, to be using skin flaps that contain lymphatic vessels and be trying to orient them? Again, we have preliminary information in all of these fields, but no studies that actually compare one versus the other. And I think finally, our most fundamental question, which is, it's hard to begin answering any of the other questions before we know the answer to this one, is how common is this? Who does it happen to? And what are the risk factors for it? And again, that's where our study, I think, is going to come in. Hopefully, we'll start collecting data for that soon, and we may have some more answers. So in conclusion, post-traumatic lymphedema is poorly understood and underreported. Lymphocytography alone should not be considered the gold standard for diagnosis. We need to understand the importance of critical lymphatic anatomic areas. There are effective surgical treatment modalities for post-traumatic lymphedema, but we should also be thinking about immediate lymphatic reconstruction and non-surgical lymphedema prevention. And then we have these areas for future study, including population frequency estimates, optimizing our diagnostic techniques and our criteria to say who and who does not have lymphedema, and then figuring out how to prevent post-traumatic lymphedema. Thank you very much for your attention, and I'm going to stop screen sharing here, and I'm happy to take any questions here. Let's see, I'm going to look in our Q&A box. Question about primary lymphedema and vascular insufficiency. Proactive surgical intervention for children for primary lymphedema. Not that I'm aware of in terms of ahead of time. Again, our focus in this talk is on post-traumatic lymphedema, and there is imaging to identify where lymphatic channels are that are interrupted. However, it's the same ones that we use, which involve injection of contrast dye. And usually we would do that after swelling comes up. All right, let's see. Next question. Would damage to the lymphatics put you at greater risk of fungal, parasitic, bacterial, viral infection? Yes, certainly. If you have lymphedema that is severe, what ends up happening is that lymph fluid, which contains bits of bacteria that we would like to actually recirculate and send to our surveillance network of lymph nodes, that tends to stay in the same area. So especially bacterial infection tends to be more susceptible for folks with severe infection. When you discuss lymphedema etiology, you do not mention lymphedema as a cause. Why is that? Well, because there are many causes of lymphedema, and we're trying to compare sort of numbers and etiology. That simply wasn't the focus of the talk. I developed lymphedema from radiation for ovarian cancer. Oh, this is a great question. How does the lymph and toxins travel out of the leg with manual drainage and wrapping if the lymph system has been blocked? Again, this isn't directly a question about traumatic lymphedema, but it's remarkable. When I do indocyanine green imaging for folks who have lymphedema and we use massage, and again, I'm probably not as skilled as my therapist, I'm definitely not, but even my sort of gentle sort of basic massage, you can actually watch the dye travel, even if it's not traveling in the normal channels, within the skin. And these little tiny side streets, if you will, the pre-collectors, can collateralize, and they're not effective or efficient at making the lymph flow, but you can get them out, however slowly, through that. So that's how that works. Can MLD stimulate VEGF-C to initiate new lymphatic growth? I am not aware of that. There are a lot of folks trying to do that pharmacologically. That's also one of the reasons we do vascularized lymph node transfers, because they secrete VEGF-C. But I'm not aware of non-operative techniques or non-medication techniques to use that. Do you feel referring clients for pre and post-op lymphatic drainage could be a new standard in healthcare after trauma, injury, and/or surgery? I certainly think so. I think our job would be to identify patients who are at highest risk, and perhaps that is a pattern of injury in the critical lymphatic areas or severity of injury, let's say, that leads us to then obtain lymphatic imaging, identify a lymphatic injury, and once that's identified, then I think it really would be ideal for patients with post-traumatic lymphedema to be referred for complex decongestive therapy. Unfortunately, there are many obstacles to that. A lot of them have to do with resources, but it may be as we see more research coming out on this that we end up doing that, and I think that would be great. Do I see a fair amount of patients imaging that have primary, not secondary lymphedema? No. I do see some, but the predominant mechanism is secondary of some sort. Can one get lymphedema of the foot after a severe sprain? I don't know, and I'm not sure anybody does. You can certainly have long-standing swelling, but in our review of the literature, there is a really limited number of studies that's actually employing imaging to look at what the swelling is from. And so it's kind of wild, I think, but we really don't understand whether that prolonged swelling actually represents lymphatic injury or if it's something else. And that's one thing that I think we should aim to find out. Would it be a good idea to start compression wraps and MLD on these traumatic injuries? Absolutely. Again, I think we need to, the barriers to that are identifying who those patients are who need it, and of course, securing the resources for that. Let's see. After having excision procedures decades ago, is it possible to have debulking done again? Yeah, again, this is not really a question directly about traumatic lymphedema. But yes, it can be. Is all post-traumatic edema lymphedema? No, it's not. There are definitely all these other mechanisms, and how can we tell the differences with lymphatic imaging? So specifically, indocyanine green, lymphoscintigraphy, these imaging modalities that have dye that is picked up by the lymphatics, and that's where you're going to get your answer. Because as we know, lymphedema is not a clinical diagnosis. There are all these different causes of swelling, from venous problems to just inflammation, lipedema, and so I think that having careful studies that really employ imaging to do this are going to be super important going forward. Okay, well, thank you so much for your questions. I think we can possibly wrap it up here.